And dear colleagues, now I invite you to take part in the very short discussion. We have several minutes. And please answer your questions. Maybe my co-chairman will ask some questions.
Yes, Natalia, thank you very much. I want to ask Gast one question. You see, I have several cases of primary anterior closure glaucoma. When I perform the clear lens extraction, no improvement. I performed Gonios nicolysis without improvement. I performed laser iridectomy, no improvement. And even medication does not help me. And the only way was to improve situation was anterior vitrectomy. What do you think about this type of surgery in such cases? What is your opinion about it?
I think if you're in a situation where vitrectomy is requiring the clinical case is requiring vitrectomy in order to generate more space and make a significant involved in the mechanism. So aqueous misdirection doesn't have to have a pressure of 50 in order to be aqueous misdirection. You can have aqueous misdirection at normal pressures. We see that a lot, of course. But I would have thought that if you're having to reach for a vitreous debulking procedure, then that suggests to me that there's an alternative posterior segment mechanism involved in that particular case.
Mm-hmm. Thank you. Thank you.
Mm-hmm.
And one more question for Augusta. What type of intraocular lenses do you prefer in the case of combined surgery? I mean, whether it's hydrophobic, hydrophilic, or probably three-piece IOLs? I think it rather influence on the position of the lens in postoperative period is influence on the deepening of anterior chamber, and that's why influence on the intraocular pressure too.
Yes, that's a good question. We use a standard lens, but I don't, we don't use multifocal lenses, and we use the same lenses that we use for cataracts, a plain single piece lens. So we don't think that will have an impact if you put the lens in the bag. I think that the type of lens shouldn't in normal circumstances influence, and it would be the anterior chamber depth would be quite stable. Of course, there is always exceptions if you have a small risk of malignant glaucoma, but if you have a malignant glaucoma, which is very uncommon, I don't think that the type of lens would make any difference. So I just use the standard lens that we use for everybody.
Thank you. Thank you.
Thank you very much. A very interesting discussion. Professor Boris Malugin, do you have a question?
I have comments. I think we are now facing a significant paradigm shift towards more clear extractions. And I do believe that for the average ophthalmologist and even for the average surgeon, it will not be a very easy decision to remove the clear lens of the patient, keeping in mind the possible complications. So if you are a brilliant phacosurgeon, that's okay. But if you're kind of, regular phacosurgeon, I think there is a big barrier to go into the OR and remove your patient's clear lens, risking complications. And I'm wondering, how do you think we should address this barrier? And my question to all the presenters, by the way, because it's probably country specific, and also I think it should be economics involved, because not every healthcare system will probably encourage you to remove clear lens in patient with high vision, with high visual acuity. So in certain countries, there are limitations of visual acuity when you can do cataract surgery. So how is that being addressed? I want to this open for everybody. Clement, maybe we'll start with you. So how do you address these issues in your country, in your university?
Thank you very much for this question, Boris, which is a very good question. I think first of all, you must be able to convince yourself that the clear lens extraction is going to help the patient. After that, I think a very good informed consent is extremely important. Usually, these patients will need a lot more chair time. You have to explain to them the benefits and the risk of the surgery. And furthermore, I think the situation will be made simpler if the patient has got significant refractive error, and also the patient does, if the patient has a significant presbyopia, that can also make the discussion easier. Because under those circumstances, by putting in the intraocular lens, you can probably correct the hyperopia. You can reduce the presbyopia with, say, for example, monovision. In my own practice, I routinely use toric lenses when it is indicated, so the patient gets the additional refractive benefit of having their astigmatism corrected as well. So I think all these require good discussions with the patients, and of course the rapport with the patient would be extremely important. But thanks very much for the question, Boris.
Yes, thank you.
Augusto, how are you addressing this?
Yes, no, I think Clement has addressed the most important topics. What I would say is that, at least in my setting, patients trust doctors, and you know, if you think about glaucoma surgery or trabeculectomy in open-angle glaucoma, if the surgery goes very well, the patient will see a bit worse. And we are used to this sort of conversations that we are able to persuade patients to have glaucoma surgery, which, you know, from the patient's quality of life is not a good surgery, but we know that there are benefits in the long term. The other thing I would mention is that in the EAGLE trial, there were over 30 surgeons, and some surgeons are going to be better than others, and we know that. It was a pragmatic trial, so the majority of surgeons, will have very good outcomes, because again, the lens extraction in this context tends to be easy. Having said that, if you are not a confident and experienced surgeon, I don't think that is I think there would be some obvious reservations. And the last comment I will make, and again, this is about, discussing with patients. Some patients are risk averse, as well as some surgeons. And so, again, if the patient is very risk averse, that's absolutely fine. Most people, will do well with the standard treatment, and you can always, have other options. But I think that, I think this should be offered as a possibility for patients. Thank you.
How about economics? Do you have any economical restrictions from the insurance company?
Well, that's a very good point. No, I think that because the reason for lens extraction would be glaucoma, or I think that we can do this surgery, we can justify the surgery because again, the indication is glaucoma, is not refractive. And of course, we will get the benefits as Clement mentioned. So we don't have such a restriction in the UK at the moment.
Okay,
thank you. And Gus, so my question is for you, if you're still with us, I don't know. Not sure he's with us. Okay, so then maybe one more question about the Gonios nicolysis. So, and again, Clement mentioned that in his talk, and there were also some publications cited that it's not really very effective. At least there are many techniques of Gonios nicolysis. That's probably a bit of confusing here. Everybody is using different technique, and that's why the outcomes are variable. So I personally like to, to grasp the iris in the mid-periphery and tear them without any gonio lens. So just to certain extent, that's not very controlled surgery. It's just more on feeling when you have to stop rather than tear the iris from the iris root. So, but in my hands, I love to do it in every posterior synechial case, and I think it's quite effective. So I believe, Clement, you tried every type of synechiolisis. So and you mentioned one that you do now. So what is your experience with these different approaches? Which one you don't recommend to us?
Thanks very much for this question, Boris. Maybe let me start by sharing my thoughts on the various studies on GSL. Say, for example, there has been this randomized control trial when the phaco emulsification alone was compared to combined phaco GSL, and it turns out that the pressure reduction was not that significantly different. My own feeling is that, well, actually it's not a feeling, but my belief is that every phaco emulsification surgery, there is a component of synechiolisis in it. In fact, you're either doing visco-synechiolisis, or if the pressure in the anterior chamber is high, the hydrostatic pressure is high, you are basically doing some kind of synechiolisis. In fact, our group performed an ultrasound biomicroscopic studies on PACG eyes before and after just phaco emulsification alone. That was published quite a number of years ago. And we demonstrated that with just phaco emulsification alone, there was a significant reduction in the extent of peripheral anterior synechia in those eyes. So I think probably with phaco emulsification, the reduction of PAS is perhaps one of the mechanisms that lead to IOP reduction. And that's probably explained the reason why when GSL is combined with phaco emulsification, the effect of the GSL may not be so obvious. And that's also the reason why I brought up that particular case series when people perform just the GSL. It seems that there is a significant IOP reduction as well, just by itself. In terms of the different types of GSL, I think so long as you can safely strip the peripheral anterior synechia from the trabecular meshwork, and so long as you can expose the trabecular meshwork to aqueous, I think it should be in theory equally effective. But of course, one main assumption of GSL is that the underlying trabecular meshwork and also distal drainage system are functional. And it has been shown in previous histological studies on PACG eyes that in some of these eyes, those tissues could have been completely scarred up. And it was believed that the longer duration of the peripheral anterior synechia may have led to the histopathological changes in the trabecular meshwork. And in those eyes, I doubt if GSL would be useful. So I think at the end of the day, patient selection is extremely important. Thank you very much for the question, Boris.
Thank you. May I ask one more question, Clement? The question concerns the Micropulse psychophotocopulation. Can we recommend this method for all patients with primary angle closure, or our choice depends on the visual acute, the stage of the process, the prognosis? What do you think about this?
Thank you very much for the question, Natalia. Basically, I look at all these lasers and surgical procedures. I place them along a treatment spectrum when I consider what surgery or laser I give to my patient. Basically, at one extreme end of the spectrum, you have got lasers such as SLT or perhaps micropulse lasers. These are least invasive, relatively safe, but you don't get a lot of IOP reduction. But at the other extreme ends of the spectrum, perhaps you have trabeculectomy, you have a glaucoma drainage device implantation. These are more invasive procedures that carry slightly higher risk, but you get much bigger IOP reduction. So I think the way that my mind usually works is that I decide for that particular patient how much IOP reduction is needed. And that, of course, depends on the level of IOP before the surgery, depends on how many drugs the patient is on, depends on how advanced the glaucoma is. And then based on all these considerations, as well as the patient's tolerance of more major surgery, then I come to a consensus with the patient as to where in this treatment spectrum suits that particular patient most. Thanks very much for this question.
Thank you very much. Dear colleagues, are there some other questions from the audience? I haven't got my co-chairman to have some questions. Okay, thank you. And now I would like to show our last slides on our webinar, please, because I think that today we have the fantastic webinar and a very nice discussion with the outstanding experts in the field of primary angle closure. And so now I would like to summarize our webinar and draw up some conclusions. Please show the slides. Okay, several moments. Okay, dear colleagues, this is the summary of our webinar that I have prepared basing on all the presentations that you have listened to before. So, the primary angle closure disease means, first of all, the eye-tobacco contact. Hence, gonioscopy is highly recommended for all glaucoma patients and glaucoma suspects in order to detect the primary angle closure as soon as possible and as early as possible. The primary angle closure glaucoma has a higher rate of progression than primary open angle glaucoma and more often leads to blindness. The pathogenesis of primary angle closure disease is more complicated than we have thought before, and keep in mind the plugged iris syndrome and the increased choroidal thickness and choroidal expansion. ZAP and EAGLE are the studies that have changed our view on the treatment options. Widespread prophylactic LPI for primary angle closure suspects is not recommended anymore, and LPI is not a method of choice in primary angle closure glaucoma unless refuse lens extraction. Think about PECA emulsification. And clear lens extraction showed greater long-term efficacy than LPI. And finally, consider the individual mechanisms of primary angle closure while choosing an optimal method of treatment. Gonios nicolysis or psychophotocopulation, transscleral or endoscopic mixed trabeculectomy, or some drainage devices implantation. And finally, SLT and micropulse psychophotocopulation are the new effective adjunctive options in primary angle closure glaucoma. However, more studies are needed for evidence. Here, let me come to the end of our webinar. Maybe my co-chairman have the final words, please.
I think we should thank Professor Kurusheva for combining us all together here today and to see these excellent lectures from all over the world. And I believe there was a lot of useful information that we've got here. And it's still, I think it's still, we are kind of in a transition zone. So, and transition is from the way we treated open angle, closed angle glaucoma to the new modalities that are not very new, by the way, because FECO is with us for many years, but it's more not the way what we do, but the way how we do and how we treat and how we select the treatment for every patient. And I want to thank really all the speakers today that made an excellent job and shared with the Russian doctors their experience and valuable insights were very much appreciated, I'm sure.
Natalia, thank you very much. It was very interesting symposium. And as I told before, the theme was very interesting for me as I'm a cataract surgeon, and a lot of cases were about combined surgery. I know that you still don't know about your next symposium, about the theme of next symposium. I suppose it will be also very interesting. And I want to see all speakers in Moscow next year. So welcome. I hope that we'll finish the coronavirus pandemic, and welcome to Moscow next year. Thank you.
Thank you, Vladimir Nikolaevich. Thank you, dear friends. Thank you and goodbye.
Thank you very much, everyone. Thank you.
Thank you. Thank you very much. Bye-bye.
Bye.